sex med doctors are very cool because they really understand the hormonal aspect of sexual function. So if you get a sex med trained doc, you're much more likely to get somebody who's also good in hormones versus then going to a hormone doc and hoping they're going to help you out with sex med. In addition, the Menopause Society, menopause.org, where you type in, not everybody listed as a menopause certified provider even prescribes hormones, so we can't assume. I mostly know this because of all the women who have told me this. So that's how I know. Okay. Testosterone therapy only for low libido. I am on an estrogen patch and progesterone, but could still use some help. I see a local gyne in SoCal. Yeah, testosterone is useful for low libido. I think estrogen and progesterone is also. Have your gyne give it a try. You can help them out by bringing in the international guidelines on testosterone for low libido, which is helpful. I have it linked. Where is it linked? If you go to my Instagram, in my link tree, it's linked. You can find it, it's free on Google if you can find it. But if you want a link to it because you can't find it, go to my Instagram, the bio, that has a link for the international guidelines for testosterone for low libido in women as a resource to print out and bring in. Gynecologists are hit and miss as far as testosterone goes. There's some that are the menopause ones tend to be more savvy on it than your straight up gynes who don't even know that testosterone's in a female body. But what we have the most data on for anything for testosterone is low libido. And there's a reason for that. It's because the FDA said, hey, we'll approve this for low libido. So then the companies did the research for low libido, which is complete gender bias because men get to have testosterone approved for low hormones, which is what I think women should get testosterone approved for, is low hormones. Libido is one symptom of low hormones in men, and I believe libido is one symptom of low hormones in women, but that's the only indication we're going to get from the FDA. So, the real world, man. We got a lot of work to do. Okay. Regarding physical intimacy, I can reliably orgasm in one position only with my husband. Is there a reason to try to get there a different way? No. If you're perfectly happy, do you. The question is there a healthy reason to try something different? Only because you want to. You don't have to do it. I mean, so I see this a lot more. I'm gonna gender stereotype, so I always want to preface when I gender stereotype, this does not mean all humans, it just means a tendency. Men find one way to orgasm, they want to orgasm that way the whole time. They're like, I like spaghetti for dinner on Tuesdays. Don't mess with my Tuesdays. Tuesdays are when I have spaghetti. Like, spaghetti is tasty on Tuesdays. I like spaghetti on Tuesdays. Don't try to make me have tacos on Tuesdays. I like spaghetti on Tuesdays. And so like, they're like, I have an orgasm. This is my favorite way to have an orgasm. It feels the best. That's the way I want to orgasm. And then like, we get marketed to these 50 different ways to have an orgasm on Tuesdays. And we're like, hey, maybe we should try tacos. But like, you don't have to try tacos. If you like spaghetti on Tuesdays, just have spaghetti on Tuesdays and you don't need to do anything else. So no, you do you. If your sex life is good, no need to try other things. Do it if you want to. Do it because you're curious. But if you go into it and you're like, this is going to be super hard because my body doesn't orgasm, like your mindset really matters when you go in to try new things. So go in with like a beginner's mindset, curiosity mindset, go in to just see what feels good. See what feels good in that position without the goal of orgasm. See if that gets you anywhere. Because the like accomplishment mindset, orgasms hate pressure. Blanket statement. Like they hate, performance anxiety. Right? Orgasms like hide. They're like, they don't want to exist there when there's too much pressure. So like if you're gonna go try new things, go in with a beginner's mind, curious, on like, just like, let's see what feels good over here. If orgasms happen, great. If they don't, perfectly fine. All right, I hope that helped. I love your work. I'm healthy and cruise through peri and menopause at 55. I'm now 57. I was diagnosed with vulvodynia though, so intimacy with my late husband did not include penetration for a very long time. I had a low sex drive. I tried vaginal physical therapy. Estradiol helped a little bit, but it got to the point that surgery was the option. No way. I'm in Virginia. I'm trying to find someone as knowledgeable as you for compounded hormone therapy. Feedback on vulvodynia, please. What year were you diagnosed with vulvodynia? Because if it was in perimenopause or postmenopause, I wonder if it's just genital urinary syndrome of menopause. Remember, let's define vulvodynia. Vulvodynia, dynia means pain, vulva means the vulva. So vulvodynia simply means pain in the vulva. It doesn't tell you why it's happening. Understanding why it's happening is useful. We can't always do that. Sometimes we don't know why it's happening, but it's useful because if this is happening during perimenopause or menopause, likely it's hormones that are doing it, also pelvic floor muscles, right? So it's very unusual for a 57-year-old to just develop the type that needs surgery. The type that doesn't need surgery but can end up in surgery is called congenital neuroproliferative vulvodynia, and that is congenital, meaning you're born with it. So those tend to be the people who are like tampons never worked, penetration never worked, and you actually do a surgery where you surgically remove the area of the vulva that has it basically has increased or ramped up nerve cells, way more than the average vulva, and it's incredibly painful to touch, and so you cut that out and they do a lot better. So basically that's congenital, so you're born with it. So that type of surgery would not be indicated usually in somebody who developed painful penetration at age 55. So Virginia, I would check out Rachel Rubin in DC. I don't know how far you are from DC. You could also check out Andrew Goldstein, Dr. Andrew Goldstein. He is in Manhattan as well as DC, and they are both the top experts in painful penetration and vulvodynia. Anybody who is down near Florida, Jill Kraft used to work with Andrew Goldstein up at the top of the East Coast, but is now in Florida. For anybody who needs resources, since the topic today is people you can go to. But yeah, so that would be my question, is when did the pain happen and why? Because vulvodynia is just kind of like a bucket where lots of different things can fit into that bucket. Alternative to Addyi for postmenopausal women. So Addyi is flibanserin, which is a non-hormone that works in the brain. The central acting dopamine agonist for hypoactive sexual desire disorder. Works in about 60% of people. It's more expensive than the hormone route. Addyi's around between $150 and $200 a month, and you have to keep taking the medication. I've had hit or miss for insurances covering this, and very safe medication. And some people, they say they tend to sleep better, a little bit of weight loss, and you can have alcohol with it. That used to be the big warning, was that you couldn't drink with it. So suggested alternatives to Addyi. The other FDA-approved non-hormonal drug for low desire is bremelanotide, which is Vyleesi. That is the on-demand injectable. So it's like a little diabetic needle. I've done it. It doesn't hurt. You do it in your leg or your low belly. They say do it 45 minutes before sexual activity for the desire part to kick in. Some women say it takes a lot more hours, like 12 hours later, then they'll be desiring sex. So I think that one tends to be a little bit more expensive. I think it's around $200 now for 4 of them, which is considered a 1-month supply. Side effect is nausea. So some people will take like a Zofran, ondansetron with that. Both of these medications are not FDA approved for postmenopausal. That doesn't mean they don't work. They work. I've actually never had insurance tell me a woman couldn't have it because they were postmenopausal. Is your insurance going to call you and ask you when your last period was? Like, they don't really know when you're postmenopausal. So it works. They've been trialed in postmenopausal women, but the FDA, I would say the FDA has undue gender bias against some humans. Viagra isn't contraindicated in men over the age of 60. Viagra isn't contraindicated in men with low testosterone, which is what menopause